I'm going to speak about some of the same issues, but maybe with a slightly different perspective from what Bernadette just presented, but there's an overlap here. I'm going to talk about the global shift in care seeking towards facilities, followed by, again, some comments on quality of facility-based maternal and newborn health care, and then looking specifically at linkages between facilities and community and household care. Well, this slide just simply shows of the 135 million live births per year, that very few actually are in developed settings. And we see that over something in the order of, you can see at the bottom, 50 million births at home, 40 million facility births in low-income settings. All of these are where the majority of deaths are occurring. So we clearly have a huge problem. We have a huge number of births, and in essence, we have to make sure that we have essential maternal and newborn care for each of those births. Well, the institutional delivery rates have been increasing, but there is a variation by region. I just call your attention to the fact that South Asia and Eastern Africa have the lowest rates. Here we see that increasing skilled birth attendance has been occurring. This is just a snapshot of some countries that were reported last year in the Health Policy and Planning Supplement Decade of Change. And you can see that in all countries, including both Asia and African countries, that there has been a notable increase in skilled birth attendance. Here's Malawi alone, which shows that essentially over the last 5 years, there's been a very sharp increase in facility deliveries. And this is mirrored by other countries. Here are data from some selected poor performing states in India. And while I don't have comparative data here, you can see that even in the lowest numbers, you see rates in around 30 to 40%, but as high as 70 and 80% facility deliveries. This represents a marked change, and we can attribute this to a number of reasons. Certainly, incentives have been provided in a number of settings for community health workers and for families, but services have become available, including appropriate drugs and tools. And then clearly there's been a change in communities and their expectations, the norms and practices. Well, not all facilities are created equal, as we know, and this presents a real challenge. I want to share with you some data that just indicates a snapshot of facilities that were reported in a SPA that was in this data. This slide comes from a 2009 supplement in the Journal of Obstetrics and Gynecology, and it shows that of the deliveries that took place in facilities, what proportion took place in facilities where health workers were trained in neonatal resuscitation and where equipment was available. And you can see the high bars. The light pink is the number is the number of the facility deliveries, and you can see the very low rates of coverage of skill and equipment. Altogether, we have a pretty clear picture here of missed opportunities and the quality gap. Well, facility birth, unfortunately, does not mean quality maternal and newborn care, but unless there is a certain set of conditions. And Bernadette has already mentioned these, but I just wanted to note these as ones that we adhere to: respectful care, skilled staff available 24/7, functional equipment, essential medicines, newborn routine and emergency care signal functions that are combined with basic and emergency obstetric functions. We know, as we've heard this morning, that newborn has not always been included with safe motherhood, although it is increasingly so. That standard protocols are used, and that lastly, that quality control measures are in place that involve data collection, using that data for action, and then measuring and the output from those processes. Well, the newborn signal functions that I wanted to mention, Bernadette has already highlighted, but I just want to call your attention to some really high impact interventions that we need to focus on. And this is a way we tend to think about it at Saving Newborn Lives, along with a number of partners, and that is, we're calling it a 3x2, 3 times 2 plus 1. The 3 means the 3 causes of neonatal death, and then 2 interventions, one preventative and 1 treatment for each. For intrapartum complications, we're talking about preventing by quality obstetric care. Treatment, of course, is by providing neonatal resuscitation, if not breathing. For preterm, the use of antenatal corticosteroids obviously reduces the incidence of respiratory distress syndrome and saves thousands of lives, hundreds of thousands of lives, and management then with kangaroo mother care. For infection, we're talking about hygiene, and particularly now the advent of chlorhexidine and in its applications in communities and possibly hospitals. And then obviously management with antibiotics. But the 3 times 2 plus 1 implies that there's also basic newborn care, including all of the essential elements that you well know. We have to look at opportunities in facilities, and I just want to call your attention to what's been happening over the last few years. We've seen, especially with the advent of Helping Babies Breathe, that neonatal resuscitation is improving and is growing and expanding. The data I showed you a minute ago was from the mid-2000s, and today we may see different numbers, but I'm not sure. Antenatal corticosteroids, we've already heard about the low coverage there. KMC, also Gary Darmstadt nicely articulated the importance of KMC, yet its underutilization. Chlorhexidine, I want to mention, is potentially something that we can take a look at in facility settings where there's high mortality, poor hygiene, and particularly when there's early discharge. And then the safe birth checklist has been mentioned by Bernadette, and then there's also the opportunity with new data that are coming in for treatment of routine sepsis and pneumonia at health centers and health posts. This is pending some trials that are due out later this year or early next year on simplified antibiotics. This is the paper showing the safe birth checklist, which has already been mentioned. I just want to mention that we have to also think about ending harmful practices, and I'll just mention 4 here. One is the overuse of oxytocin, augmentation of labor without appropriate monitoring, and the consequences of that. Also, routine suctioning of all newborns is no longer recommended, but is still, unfortunately, oftentimes practiced. And we see oftentimes in facilities, in many settings, an unfortunate separation of mothers and newborns for not very good reasons, and this is something we really have to address. And then elective C-section prior to 39 weeks is another important issue. With respect to referrals, you know that there are community-based systems that are needed, as well as referral systems that I won't go over now to tertiary centers, but I do want to call your attention to the fact that pre-referral care and referral protocols really are essential for maintaining quality of care. I just want to end with a thought about facility linkages. Many or most mothers and newborns are discharged or they leave the facilities within hours of delivery. There's a need at the hospital to ensure pre-discharge examination of mothers and babies, including observing breastfeeding and counseling and danger signs and arranging for a postnatal home visit. And on the community side, there's a need then for those community health workers to make those visits within the first 1 to 2 days and to check on the mother, refer for danger signs, and counsel on practices. In India, just 2 slides to show you some data from a project in India. This actually shows in directly observed cases, how often women at discharge were advised about maternal danger signs. And here you see the same showing those observed cases, looking at whether neonatal danger signs were provided through counseling. This is really, I think, a very alarming data, and we need to think seriously about it. So we have simple approaches that we can use, including developing discharge checklist and mHealth technologies to connect with community health workers, and then postnatal home visits. Lastly, I want to conclude with the fact that we need indicators, particularly for quality of care, looking at impact and outcomes, and possibly a new indicator that might look at neonatal death in the first day and fresh stillbirths. We clearly also need to improve routine monitoring, particularly with some of the newborn health signal functions, and then expand death audits. Well, we can make it happen. That is high coverage, high quality, and high demand for facility-based maternal and newborn care. One quote I want to leave you with. This is from Uganda, and to just read down in the bold print. This was a quote from a health worker in a facility after there had been training in maternal and newborn health care. In particular, this is a reflection after a case of neonatal resuscitation. And the health worker said, "Now we are not afraid of handling this tiny human being. Previously, we used not to audit these deaths, but would just say, sorry, sorry, without establishing the cause of the problem or finding solutions. No one was responsible or accountable. But now we expect the woman who comes to deliver to go home with a live baby." I think that's the message that we need to consider today, is that is our charge. Thank you very much.